My name is Felicia Wong. I am a consultant for Frontline AIDS, working with them to support FGS and HIV integration. I'm also co-coordinating the FGS integration group, which Frontline AIDS has founded. Welcome to our session today around including FGS, or female genital schistosomiasis, within the current Global Fund round proposal, also known as NFM4. Please, I'll hand over to Leora to introduce yourself.
Good morning, everyone, or good day, depending on which time zone you're in. My name is Leora KC, and I'm the lead for HIV prevention advocacy with Frontline AIDS, based in South Africa. And I've been working with the team in Frontline AIDS to try and make sure that we integrate FGS into HIV programming.
And also, so I think just, Frontline AIDS is hosting this session, as I said, part of the FGS integration group, but it's also part of our work around bringing cross-sector collaboration around this neglected condition that also has an impact on HIV and women's health. So today's session is really about raising awareness of FGS as an HIV co-infection comorbidity, and schistosomiasis, or as you're probably more familiar with hearing, is bilharzia endemic countries also eligible for Global Fund NFM4, which I believe stands for New Funding Model 4, but it's a current funding round. Identify opportunities to include FGS within the proposals, but as part of integrated HIV and SRHR services. Do a bit of thinking together around how we can leverage existing HIV and SRHR platforms and processes, and in this case, the Global Fund plus other opportunities. And then really a chance for us, if you saw across the poll, kind of, there's those of us that are working in HIV, sexual reproductive health, NTDs on FGS, and also different actors and stakeholders across the Ministry of Health, donor partners, and CBOs and NGOs. Just to kind of is that this session is for you if you are familiar with the Global Fund and you're already working in HIV or sexual reproductive health, and you are familiar with FGS, or female genital schistosomiasis. But if you're looking for general information on either the Global Fund or FGS, kind of like a 101 basics, this is not the session, because we will not go into detail for the around this. We will be sending around after the session in the follow-up email and the recording a list of resources if you want to find more details about both the Global Fund and FGS in itself. And so the session is, we're welcome introductions. We're doing a brief overview of the Global Fund process. And then really the bulk of our time together is really to create a space where we can share some lessons learned from Simon, Robinson, Patricia, and Victoria, Dr. Gamba, around their experience around FGS. And also there are other people in the room, actually plenty of other people in the room that have also been working on FGS and building partnerships around FGS. So please, everyone, let's have this just, as kind of conversation together to move forward. And then we'll have a summary after. I'm bringing key messages from our conversation, and a lot of the the Q&A and the suggestions and things will move into our next session, and we'll use that as a learning opportunity and convening space for all of us who are working on FGS and trying to bring integration to the front. So I didn't want to, I didn't want to leave us not actually saying what FGS is, and literally this has been even less than basics, but just for those of you who may still be hanging on and joining anyway and staying to listen, who may not be familiar with FGS, female genital schistosomiasis is a condition that affects up to 56 million women living in sub-Saharan Africa. It's caused by this one of the main parasites that causes bilharzia, so schistosomiasis hematobium, which in particular impacts the urogenital tract and system, so urinary and also reproductive tract. FGS has been a neglected issue that has significant impacts on women's health, but it falls in between the neglected tropical diseases or the bilharzia response and also sexual reproductive health, because basically within the NTD side of programming, it won't treat the morbidities or the damage that happens within women's reproductive health system. And I think one of the things that that keeps it kind of as an unknown new thing is that it remains undiagnosed, and many healthcare providers don't know about it, but yet it presents like a STI. So a lot of the symptoms may look like a sexually transmitted infection, which leads also women to go to care many times. You see that cycle on the left, being misdiagnosed, going back, getting care that doesn't work for them. But then also there's kind of the social and relationship impacts of being accused of having sexual activity, etc., and experiencing increased risk for gender-based violence. And then for us in this session, really, FGS is also associated with an increased risk for HIV, and also more emerging evidence is showing that increased risk for HPV as well. And then just, this is data is always emerging, but you can see that these are some of the overlaps of HIV prevalence, hematopia prevalence, and infertility. And then I guess just for us is that FGS, or female genital schistosomiasis, is already included in a number. So we're not starting from scratch. It's included in a number of policies, but in particular I think the relevance for the Global Fund is around FGS's inclusion in the global AIDS strategy, and in particular around the relevance of this within comprehensive sexual and reproductive health in bilharzia endemic countries. And then the WHO on the right, that's the NTD roadmap that calls for stronger integration across disease areas. And then the reference on the left is really a joint policy brief that was released in 2019 from UNAIDS and WHO. And not only that, there is already a framework as well around integration. So we'll share the slide set and all the references. So that is me. I'm just doing a really quick introduction to what we are doing today. And I'm going to hand over to Leora to talk through just a brief overview of the Global Fund current funding process. So over to you, Leora, and just let me know and I'll do the slides.
Sure. So as Fee mentioned, we're not going to go into a lot of detail around the Global Fund, how it works, how the funding processes work. We hope that everyone on the call has some idea about it, but just largely go into some detail around how we see FGS possibly fitting into a Global Fund program. So currently, most countries are in the funding period of 2023 to 2025. And as you can see from this graphic, the application process takes 6 to 9 months, and then the grant implementation period is a period of 3 years. So if we're looking at the Global Fund strategy for 2023 to 2028, their strategy is a world free of the burden of AIDS, TB, and malaria, and better equitable health for all. And the word equitable was added to the Global Fund's new strategy to underscore their commitment to addressing inequalities in order to achieve their grants. So this new strategy of 2023 to 2028 will guide the Global Fund for that period, and its impact will be measured in 2030 alongside the world measuring the impact of the SDGs. So as you can see from this graphic, in 2023, we have 3 funding windows. And these are funding and review windows. The first window, which some of the countries that are on the call are in, is in March. The second window is in May. And then the third window is in August. Next slide. So if we're looking at, the Global Fund strategy and what the new funding model for is funding, they're funding HIV, TB, and malaria programs, which include a number of different programs, key population programs, adolescent girls and young women, etc. But they also funding programs on resilience and sustainable systems for health. And this obviously also contains really important elements for health systems and community strengthening, which is important to achieving the disease programmatic areas. Next slide. If we go deep into the global strategy, they've got 5 sub-objectives around a particular, objective on maximizing health equity, gender equality, and human rights. And we've highlighted 2 on this slide that we think FGS could fit into, and that is supporting comprehensive SRHR programs and strengthening the integration with HIV. We know that all funders are looking at strengthening integration because it's more cost effective. And if we've got a young woman or a girl, for example, that's receiving an HIV service, it makes sense to integrate other types of services in that space so that you make the best of having her present for that time. And another space in which the integration of FGS could be seen is through programming for adolescent girls and young women, as well as key and vulnerable populations and their partners. Next slide. So here we're looking at the sub-objective around integrating comprehensive SRHR programming and strengthening the integration of HIV. And we can definitely see that the integration of FGS could contribute to strengthening SRHR partnerships and strengthening the integration with HIV. Because we know that that's incredibly important, and there would be a further integration of FGS there. And then also a really important point is around 2.3, where we could see addressing FGS could be an entry point for preventing and addressing some gender-based violence. The reason for this is that FGS is often misdiagnosed as an STI, and some, young women or girls are perceived as being and accused of being promiscuous or having multiple sexual partners, when actually they don't have an STI, they have FGS. And so we do think that this is also a really important entry point for FGS and fitting under the sub-objective for the Global Fund. Next slide. So if we're looking at integrating FGS on a realistic, in a realistic way, what does it actually look like? A lot of the panelists today will give you some idea of work that they've done so that you can get an idea of what it would look like in reality. But you can see that FGS could be incorporated into multiple areas of HIV service delivery. And that FGS is not a standalone issue, but it's best integrated if one is doing HIV or SRH services. So for example, if you've got peer educators or community healthcare workers going out and doing prevention information and providing commodities for different populations, such as adolescent girls and young women, or key and vulnerable populations. And if they're providing that information for HIV and STIs, for example, they could, in the same space, provide that information for FGS. And there can be a similar integration within testing, treatment, care and support, and sensitization, for example. So there's definitely ways to integrate FGS into all of these HIV service delivery levels in a way that can address FGS easily and cost effectively. Next slide. So if we're looking at realistically integrating, trying to get FGS included in your Global Fund grants for your country, we want to highlight one of the most important, activities that take place in the lead up and in your funding review windows, and that is the country dialogue. The country dialogue is essentially a space where most of the decisions are made and the priorities are developed for the proposal. So as you can see from this graphic, there's a lot of stakeholders that are part of the country dialogue, and there's a lot of people that sit in this space. So if you ever wanted FGS to come up in these dialogues, which would be integral. You would need to make sure that these stakeholder groups have the opportunity to input in these dialogues and can mention FGS so that it's documented as having come up in the country dialogue and as a community priority. And then it can feed into the national prioritization process. So, for example, you could work with other civil society groups and organizations to make sure that FGS is brought up in these dialogues. It could also come from working with youth networks. It could come from working with other technical partners as well as with government. And that is something that is integral if you want to get FGS included in a global fund grant. It has to come up in the country dialogues and documented. So as part of this, Simon, who is a panelist that you were introduced to in the beginning, he's the executive director for Pakacheri, and he's actually been doing significant work in Malawi in trying to get FGS included in the Malawi NFM4 proposal, as Malawi's in window 1, which is the March deadline. So Simon, I'm wondering if I can ask you, why did you feel it was important to include FGS in the Malawi NFM4 proposal?
Thank you very much, Leora, and thank you very much, everyone, for joining. I will briefly explain regarding Malawi and why we decided to start advocating for inclusion or integration of FGS into the Global Fund proposal. Like it has been presented in the introduction, Malawi is endemic to bilharzia, and several studies that have been conducted in Malawi do attest to the fact that bilharzia is very endemic, and it mostly affects women. In terms of prevalence, studies show that about 40 to 50% of Malawians are at risk of getting affected with bilharzia, and the prevalence is estimated at 50%. As a country, Malawi, one of our country is Lake Malawi, and people may be thinking that maybe bilharzia is just endemic along the lake shores of Lake Malawi, but it is also prevalent in offshore districts, and it is even highly endemic in those areas. In terms of FGS, studies have been conducted, and the prevalence rate of FGS is estimated at 21.5%. And to underscore that, one of the youngest girl that was found to have FGS was a 15-year-old girl. And when they were diagnosing her, the suspicion was that she has cancer, only to find that it was FGS. And again, in Malawi, from the studies and narratives that are happening, you see that FGS, knowledge about FGS is very, very low among the communities, but also among healthcare workers. So among the communities, especially women who usually do some of the chores in the water bodies, they become infected, and they end up having FGS because maybe the bilharzia have stayed longer in their bodies. And eventually, within families, they're accused of having STIs, as it has been said. Misdiagnosis is very, very common because healthcare workers are not aware of it, and there's a lot of discrimination, stigma, etc. So being a neglected disease, you will see that because of this lack of knowledge, women who are already disproportionately affected by HIV are the ones who are also affected by bilharzia, meaning that they're further being marginalized, and bilharzia mostly is affecting women who are living in the rural areas of Malawi. Now, if we talk about issues of leaving no one behind, universal health coverage, and all that, you see that Malawi really needs to look at how FGS can be integrated in the Global Fund proposal, but also in other funding opportunities that Malawi has. So with all these reasons and looking at the vulnerabilities of mostly women and adolescent girls and young women to FGS, we decided that we need to start engaging with government and the various donors to look at the possibilities of integrating FGS into SRHR. And we embarked on that advocacy journey where we had to consult with the NTD department, that's Neglected Tropical Disease Department of the Ministry of Health, National AIDS Commission, and other partners to look at how can we make sure that FGS is included. Lastly, I need to emphasize the fact that it remains a neglected disease, and I will explain further that in our efforts, the challenges that we have encountered, that for those that are planning to integrate FGS in global funding and in other opportunities, must start thinking about now because I think there's so much that has to happen, but it's doable because it's justifiable that people actually see how behavior is putting women and adolescent girls at risk of FGS. Let me stop there for now. Thank you.
Thank you so much, Simon. I think it's really good, and it's amazing that you've shown the context of Malawi and why you decided to really work on trying to get FGS included in the Global Fund NFM4 proposal, as well as you say, other funding proposals. So thank you so much. Kate, I'm just doing a check-in on the chat. Have there been any questions?
No, we are happy that people have introduced themselves, but we don't have any questions yet. Thank you.
Great. I mean, I'm wondering, in case there's any burning questions that you've not written into the chat around the presentation that was just done, perhaps we want to open the floor for a few, a minute or two. If anyone has any questions, please raise your hand. And you can ask Simon about the context of Malawi or anything related to the Global Fund. Okay, great. So it seems that everything's clear. Fantastic. So now we're going to go into a panel discussion, and I'm going to start with Simon again. And just ask, we're going to ask a few questions to our amazing resource people that have done work on the ground around trying to get FGS into funding proposals, been doing active advocacy for FGS in their countries, as well as doing actual implementation and clinical work on FGS. So Simon, thank you for your context of Malawi. I'm wondering whether you can speak a bit more around your experience in trying to get FGS included in the Global Fund proposal, specifically around integrating it with HIV programs. And what have been your challenges?
Thank you, Dora. Indeed, I think as Malawi, based on the context that I provided, we embarked on an advocacy journey to look at how we can integrate FGS into the Global Fund proposal that is NFM4. I think just to be concise, I think firstly, it is important that this advocacy journeys are started earlier so that you have enough time to engage with the relevant government officials, policymakers, but also other stakeholders. Our experience has been that as much as people have actually started seeing the importance of integrating FGS into the Global Fund proposals, one of the challenges that we have faced is the issue of policy in terms of HIV. For Malawi, and I think other countries, maybe other people can also share, for the Global Fund proposal, the Bible that is used, or the basis, is the National Strategic Plan for HIV. At the moment, the National Strategic Plan for HIV in Malawi has not yet mentioned FGS as one of the key areas in terms of integration. So during our advocacy journey where we took advantage of the Civil Society Advocacy Forum. This is a grouping of CSOs that will work together, mobilize and speak with one voice. When we started on that journey, one of the key issues from the policymakers' point of view that came out clear was that do we have FGS in the National Strategic Plan? Because Global Fund will also be looking at what the strategic plan is saying, because we have to address exactly what is in there. So we continued engaging, but also looking at some of the international global instruments, like the UNAIDS strategy, look at the World Health evidence, but all that, as much as people will say yes, but they said we need to look at revising the NSP and ensuring that we are mentioning FGS as an issue that can be integrated. So one of the advice that we got was that when we are reviewing our NSP, which is due to review, then we could be looking at opportunities to integrate, to bring in FGS as one issue that has to be addressed. Talking about integration, I think integration, it was very clear that everybody did accept that opportunities are very clear, because if you look at what Leora did mention at the end, that you're looking at in terms of raising awareness, already we have peer educators on the ground, where within their peer education trainings, we integrate FGS, and it doesn't require like an extra budget. It's just like putting together content for FGS. In terms of healthcare workers, they already are trained on STI cervical cancer screening. We just integrate that into the current training manuals or training guide. However, the obstacle was, do we have it in the NSP? So what we realized was that if you had started maybe 3-4 months before, we could have had an opportunity to see FGS going into FM4. Just to mention that the work that we did in Malawi was just in December, from maybe close to mid-December to end of December. Comprehensively, it was time consuming, but we did manage to move and shake the policymakers, and we're believing that the conversation that we've started now is going to be accelerated in 2023, so that as we are reviewing the NSP, we must bring in FGS, because you know that once it's in, maybe at some point we can make a case and say, can we integrate FGS in the existing? So at the moment, we're putting our fingers crossed. We just finished community dialogues as part of the NFM4 development, where because of the challenges I've mentioned, we were unable to include it, but the conversations are still going on. So in summary, I think we need to start our advocacy on FGS earlier, give it more time, but also making sure that in our policy documents like the NSP and HIV prevention strategy, in whatever we call these documents in the respective countries, we must mention FGS, and then FGS was easily CSF being integrated in any funding opportunity, whether PEPFAR or Global Fund. Let me stop there for now. Thank you.
Hi, so Leora and I are both going to just kind of take turns asking panelists questions. I see Kate's hand up.
Thanks, Fee. Yes, I have a question. I've got 2 questions. One comes from the sheet where we invited people to ask questions when they registered, and it was asking what knowledge we have about how FGS increases HIV incidence in women, and whether or not we have an estimation of the proportion or numbers of women who got infected this way through, you know, what's the additional risk, I guess, of FGS for HIV infection. And then I have a question from Judith Gabidi, sorry, I can't pronounce your name, Judith, but what are the plans to integrate FGS diagnostic, prevention and treatment services into sexual and reproductive health services and into policies and programs? And I'm guessing Judith is asking that specifically of Simon and Malawi. Thanks.
Yeah. Great, thank you, Kate. So in regards to the first question around what are the estimated risks for HIV infection in relation to FGS, and There are a number of studies that have been done that have shown a 3 times increase of risk for HIV infection amongst women and girls who also have FGS. I think I think we bring this up, and I think Simon will also speak to, is that there is a lack of data at the moment about FGS in itself, meaning that there are broad bilharzia, and please also colleagues who are working on bilharzia, please do please add. There are bilharzia surveys, and there's a sense, but because there are different types of bilharzia, sometimes not that kind of detail isn't always the data isn't available, but there are also calls at the moment. There is there is evidence that backs up the connection between increased risk for HIV and FGS, and we can send that along. I've made a note to send that resource along in the follow-up email. There was a review of current literature. And then the second thing is that because of this, there are ethical, ethical considerations around FGS and HIV studies, meaning, we wouldn't, just allow people to who have FGS to be exposed to HIV or vice versa. There's that, that ethical consideration around that, but also there is also movement, though, meaning that there is currently a project, and many of you may have heard of it, that is looking around finding out FGS burden within certain countries. There's a new piece of research. The RFP is out through Core NTD, and I can put that in the chat in a minute. And also we've through Frontline AIDS and the FGS integration group, FIG, we've been exploring ways to do some HIV modeling, because I think that is one of the questions, is around that direct relationship, but ethically we can't do kind of trials on that. And then I'll turn over to Simon for that second question. Were there plans to integrate FGS diagnostic, prevention, and treatment services into sexual reproductive health services, policies, and programs?
Okay, thank you very much, Felisa. Thanks for the questions. Maybe let me start by adding to the first questions, because we had intensive consultations with gynecologists in Malawi. And in terms of the risk of infection, I think from the studies that they provided, it shows that women who have got FGS are 3 times more likely to get infected with FGS, because basically what they present is like another STI, where they've got lesions in the vagina that exposes them to provide. In terms of plans for FGS diagnostic and prevention, basically in our consultations, one key issue that was debated heavily was looking at how do we position FGS within SRHR. So should we focus on diagnosis, or should we focus on prevention? So when you look at diagnosis, I think mostly people are focusing on how much will that cost, because if you look at the issues of, I think the diagnosis of FGS is done through PCR or colposcopy, the equipment of which is very expensive. And then secondly, in terms of prevention, it is either the mass drug administration with Praziquantel. Again, the question was, would Global Fund allow to buy or to purchase Praziquantel, because they're already purchasing ARVs, PrEP, etc. Would that be a position that will make Global Fund get convinced? Or we focus on prevention through integrating into existing, for example, cervical cancer screening, STI diagnosis, and then in terms of awareness, we look at how do we include it in the ongoing PA education sessions, because it doesn't require a lot of financial investment. So these are some of the discussions that we had in-house to look at how best can we position FGS so that it is easily acceptable within the Global Fund, so that once it is integrated, then we can be looking at the other issues that are more expensive, because we're in the platform now. Then we can be making cases in terms of, do we need diagnostic equipment? Do we need to support mass drug administration, so on and so forth. And then finally, in terms of the link between HIV and the HIV, FGS, viral load, yes, we need more information. There's a gap on that one, which was highlighted. However, the gynecologists that we've been working with did present that those with FGS have demonstrated that their viral load becomes very high if they're HIV positive, and then it increases their transmission rate of HIV. So treating FGS will also result in reduced viral load. But they did allude to the fact that more studies need to be conducted to make sure that we provide good evidence or strong evidence on that one. Thank you.
Thanks very much, Simon. And I think this actually just flows really naturally into the question that we were going to ask Robinson from LVCT. I think similarly, what are, LVCT has been integrating, piloting FGS programming into your work. I think similarly, what are some of the ways that you've been including FGS? How did you integrate FGS into your DREAMS project? What worked well? What was challenging? And I think just kind of that similar story for LVCT and the Kenyan context, because I think you'll give us that other, kind of like the other journey, kind of the other pathway as well around integration.
All right. Thank you, Felicia, and hi everyone. I'm really delighted to be here to share our experiences on how we integrated FGS into our programming. All right. So the reason why we chose to go the integration way was to be able to provide person-centered care. And when we looked at the places where we implement our HIV programs, we saw a lot of co-endemicity of schistosomiasis, which led to FGS, there's HIV, and the populations that we work with are very vulnerable to HPV. So, being driven by implementing innovative projects, we decided to give integration a go. So let me share some experiences about how we integrated FGS into four key areas. So the first area is in the DREAMS project, which is a community-led intervention that seeks to reduce HIV rates amongst adolescent girls and young women. So what we did is we started off as an implementation science project where we build or strengthen the capacity of the mentors, who are peers to the adolescent girls and young women and who provide support to adolescent girls who are vulnerable to HIV. We sensitize them about FGS, how to identify, basic symptoms of FGS, and refer their peers in the DREAMS project to primary healthcare facilities. So we also built the capacity of these mentors using very simple tools, which we'll be happy to share. Very simple tools on how to educate adolescent girls and young women about FGS and the risk of FGS to HIV. The second key area was in cervical cancer screening training, where we partnered with the county government and primary health workers to modify the cervical cancer screening project, which is a 5-day curriculum. So we tried an innovation where we took one day and focused the content for one day on FGS. The half of the day was about the theory and how the lesions look like. And the second half of the day was the practical, where using very simple visual pelvic examinations, we strengthened the capacity of primary health workers. These were nurses and clinical officers. We strengthened the capacity on how to identify FGS lesions and differentiate them from other pathological lesions, such as whether it was HPV, STIs, and any other lesions that were there. The third area was we enhanced the capacity of cervical cancer, of our community health volunteers to ask community members as they were doing household visits to ask whether there were any signs of related to FGS, and we train them again using simple materials on what are the symptoms of FGS and urinary schistosomiasis. And we ask a basic question: is anybody in this household seeing blood in urine? Then use that as a baseline question, and they would ask further questions for symptoms of FGS. And again, refresh them on how to refer anybody with such symptoms for primary health care, further care and diagnosis, and they would follow up. So the fourth area and final area that I'll talk about was we sensitized primary health care workers in the level 2 facilities to also inquire about FGS symptoms or schistosomiasis symptoms, because we realized at the beginning, they said there were health workers were seeing a lot of STI issues, and they would automatically prescribe antibiotics, for treating the so-called STIs. But then again, when we probed further, we realized, they needed to raise the index of suspicion, and they were probably treating FGS symptoms as STIs and prescribing antibiotics for their own use. Now, in the next stage, Felicia, you asked the question of what worked well and what did not work well. So I'll share my reflection on what worked well. So the first area was the ownership was very strong at county level. Our health system is devolved, where we have subnational county levels, being able to take leadership about and making decisions about their healthcare. So we worked very closely with the county government and the communities where we work to identify hotspots where schistosomiasis occurs, to design materials and the curriculum using the local phrases. So that really helped with ownership and in the integration process. We also worked very closely with the Ministry of Health at national level. So we were really pleased when the Ministry of Health took all the materials we are working with, which are the communication materials, the curriculum, and scaled this up in a totally different part of the country, the coastal region of Kenya. And that was really helpful for integrating and really validated the materials that we were using. Now, there are areas that didn't work very well, and these are areas that we can work on further. The first one was financing for schistosomiasis and FGS. So in the time when we started sometime in 2021, we've not been able to crack the incorporation of FGS and schistosomiasis into the routine program-based budgeting system. So that's continuing work that we're working on. Human resource for health challenges also are quite prevalent, where we experience challenges and industrial actions in the counties where we are working. And finally, and this is an area that we also found quite troubling, was we didn't have a proper mechanism for recording epidemiological data. So, from the very beginning until, and we're still working on that, we still don't have a system of documenting epidemiological data where we record what is the prevalence of FGS and even urinary schistosomiasis. So let me pause there and stop for questions. But then just to let you know, I have a colleague of mine, Patricia Jekonaya, who will have a tag team with in the course of this discussion. So thank you very much.
Great. Thanks, Robinson. Yes, please feel free to ask questions in the chat of Robinson, of Simon, around Global Fund. One of the follow-up questions, Robinson, I want to ask, and I have one for Patricia as well, is I see that I think Dr. Gamba hasn't made it to join us yet, but I just want to ask you a little bit about like the importance about engaging, I think, with, kind of physicians and doctors around FGS? Because I know that Dr. Gambo was also really involved in one of the initial projects as well. And how would you recommend involving kind of doctors and physicians, OBGYNs?
Right. So that's one of the things that we started off sometime in 2021. And when we did a baseline survey with our primary health workers and even the more senior clinicians, we identified that most of them did not know what FGS was. And some of them would vaguely remember that, oh, there was a unit on genital schistosomiasis in medical school or in medical college. So again, awareness was one area that we can work with such professionals, just to raise awareness about FGS, and that will involve one, training health workers at facility level. It can be through continuous medical education or CMEs, and even sensitizing the professional association. We have a number of professional associations who we can sensitize through their different platforms where they meet. And another area that we were exploring was to advocate for the inclusion of FGS in not just in pre-service training, but in service training where they go for refresher training. So that's a work in progress, but I can invite my colleague Patricia to jump in, please.
Yes, yeah, great. Welcome, Patricia. Love to could you share a little bit about just that, LVCT often also translate that research and operational research into policy, and what your experience has been at LVCT around policy advocacy space around including FGS, and actually even beyond, because I think we've done some work globally and with Leora as well.
Thank you very much, and I'm glad to be here. So just sharing our experience in advocating or translating the evidence from the FGS pilot into policy, or even just influencing the little integration within other programs. So first of all, it was for us to be able to just package that evidence and begin the conversation within the county, that is the sub-national level. The government at sub-national level, because our health has been devolved. So working with the county health management teams to be able to understand FGS, and also to be able to pick it as a priority for their counties, so that as they do their county plans, then FGS becomes part of the diseases that they're looking at. And that then makes it easy to continue advocating for some budget allocations to ensure that it is integrated and mainstreamed across other services. But also leveraging on the opportunity that the counties play with regards to influencing priorities that PEPFAR fund within their own counties. And also the fact that these counties also participate in national technical working groups. So while we sit in the national technical working groups as a civil society organization, having the backing and the support of the counties is very important, because then it is picked by the national government, and that has potential to be included in the national policies. So even as we move towards looking at some of the policies we have in country, both at national and sub-national level, now we have FGS as a conversation, and we are able to pull in the various stakeholders that we have worked with. Also picking the lived experiences of some of the women who have benefited from these services, and having the voice of the users being part of that advocacy to really convince on the need to focus budget and prioritize FGS as a key issue. Also looking at platforms at global level as we keep redefining the SRH package, and the emerging issues, FGS being one of them. If we are talking about a woman, it's important that we look at her holistically. And so anything that can affect her, and when she's going for those clinics, how do we ensure that this is actually part of a comprehensive package? So now the advocacy even within the SRH program is to talk about FGS as a key issue as we look at cervical cancer, as we talk about HIV. We also ensure that we are addressing other multiple issues that a woman may be facing. So those have been some of the ways that we have been able to explore and continue to work on, and currently also looking at engaging within the global fund writing process and having key strategic people sitting within the writing process and ensuring that this is incorporated within the writing. Over.
Yeah, thanks so much, Patricia. I'm going to hand back over to Leora now.
Thanks, Patricia and Robinson. I think as well as Simon, you've given real life like examples of what you've done, in Kenya specifically with LVCT Health and trying to actively integrate it in. Simon, I'm wondering, seeing as you started this process, as you said, mid-December last year, and you sort of just jumped into it to try and get FGS included. And you mentioned the difficulties of having it not included in the NSP, which is something you're working towards. What would you have liked to have known before you went into the process? And what information and support do you feel that people need to make sure they have, should they wish to do something like this? And what are the core pieces of information they need to have at their disposal?
Thank you. I think basically, firstly, I think if we focus on the Global Fund proposal and inclusion of FGS, then we need to understand the requirements from Global Fund in terms of what do they fund and what is the basis for their funding. In which case, we're looking at the national strategic plans for HIV that countries develop, because they look at, is it something that has been planned for that country? That came out clear among most of the policymakers that we talked about. Secondly, is to understand what FGS is and what is the link between FGS and HIV transmission. Some of the questions that we asked by people that we consulted was, do we have evidence that links FGS to HIV transmission? What is the likelihood of someone who has FGS contracting or transmitting HIV? Does it link with viral load? What are the issues? But also finally, it is important to look at, if we are going to include this in the Global Fund proposal, what is it that would easily be accepted, because it will easily be integrated in the ongoing intervention. So, for example, one key issue that came out clearly was that already Malawi does receive funding for Praziquantel, which is available in hospitals. The thing was, maybe from what Robinson has said, how can we promote, create demand for Praziquantel for people who have been exposed to infected water, because that would be a very, very clear or clean prevention message that can go to people who have been exposed and at risk of developing FGS. And then finally, it is about understanding what the Minister of Health through the neglected tropical disease department in the country is working on and what the challenges they're facing. For example, in Malawi, we found that as much as the department is there, but I think they needed guidance in terms of how can we take studies that have been conducted in Malawi, but also the challenges of FGS to a certain level. So our coming in to bring in this advocacy was an excitement to the department, and they've been very supportive, because they were almost like stuck to say, we can't take this everywhere, but now they've actually seen that there are opportunities out there where we can address FGS as long as we have the required evidence. Thank you.
No, thanks, Simon. I think, of course, countries would definitely want that evidence. So that's really interesting for everyone to note around what you would definitely, what kind of information you would need, or and please do reach out to us if you need any support. Ken, I'm wondering whether I can call on you and just ask you from your perspective around the Global Fund. And the processes that need to be followed. We know that there are strict processes that have to be followed, so there's certain boxes that have to be ticked. So what advice do you have for everyone on the call around the Global Fund processes and obviously getting FGS included?
Yeah, thank you, Lyra. I think Simon Robinson and Patricia covered a lot in terms of the engagement at the country level from the health side perspective. But one thing, so I'm part of the Global Fund board delegation, and one thing we have worked closely with the Global Fund Secretariat and technical partners is around human rights and gender. And I think it's important that FGS has a comprehensive approach and focusing on gender inequalities, because in the funding requests, applicants need to show how the gender-related barriers, why they exist, and how they impact health outcomes. And this will be important for the technical review panel to see the link. So I think it's important to have that gender or really flesh it out and part of the narrative that is presented. And another thing is research. I think operational research is key. Community-led research needs to be there. And I think that's always sometimes we miss out on, focusing on service delivery. And I think this is not just for this proposal. We're looking at long-term, not just from Global Fund, but domestic financing. So the more evidence and research we build upon what's there is important. So yeah, so those two.
Thank you, Kenna. Some really important takeaways for the process. I think definitely ensuring, obviously, that gender lens is shown is really, really important, because ultimately trying to get FGS included in a Global Fund proposal is all about those young women and girls that we're trying to protect. So thanks. Sophia, I wonder if you want to start with the next session around going beyond.
Yeah, thanks. Thanks very much. And also I'd like to welcome Dr. Gamba to the session. She's a obstetrician gynecologist based in Kenya, and we mentioned her as part of the LVCT project. Welcome. Kate.
Hi, just thought I'd let you know what's been going on in the chat. So we are happy with our panelists answering the questions in the chat. Thank you. And so we have a question that was about whether or not, following the work of LVCT, whether or not there was an increase in reporting of FGS incidents. And this is where Robinson, pointed out the problem of the difficulty of documenting reporting patterns, the weakness of data. So I just thought I'd mention that question was asked and answered, and also that Simon also answered the question about data, saying that they are planning the review of the National Strategic Plan for HIV in Malawi, and are planning on putting together a team of researchers, gynecologists, NGD experts who will start to gather more evidence of FGS prevalence in Malawi. And finally, a comment from Cynthia, just saying countries need to prioritize high impact. Sorry, that's Cynthia from the Global Fund. Countries need to prioritize high impact interventions. So data is really crucial. So costings to justify integration. Thanks. That's it from the chat, folks.
Great, thanks. Yeah, I think thank you, Cynthia. I think that's really important. I think we talk about the interventions and how we integrate and the costing, and being able to bring that evidence to Global Fund proposals is really critical. And I think also hearing from Robinson similarly for really all the policy spaces as well. So we've been, and I think our conversation in this session was about how do we support including and integrating FGS within Global Fund proposal in this round, but I think it's come out really clearly about how, this is just one moment in a way to get started, and that there are so many different levels where this integration and advocacy needs to happen. And I guess, as is the nature of FGS, in a very integrated way. So if we're looking about kind of right now, kind of the going beyond NFM4, and this is a question for everybody, and it's really about, what would your advice be around promoting and advocating for FGS? Simon, Robinson, Victoria, Patricia, and how to, integrating it into national policy programming and different funding opportunities, like leveraging what's there for integration, because I think we know that it would never, integration itself is not standalone silo, but has to be really part and parcel. FGS has to be part and parcel of everyone's kind of everyday work. So maybe if Dr. Gamba doesn't mind, I'll call on her first. What do you see as opportunities around integrating FGS within the spaces that you're working in within medical curriculum, health provider, healthcare, physician training? I know that you've been really involved in FGS as well, and where you see kind of some of the opportunities.
Thank you, Felicia. FGS is something, as you've said, that needs to be integrated in all aspects of reproductive health. One of the things that I do get when I interact with the physicians is always, I've been seeing this, but I didn't know it was FGS. So the eye only sees what it knows. So part and parcel of trying to make FGS stand on its own is just empowering our physicians to know what is FGS, how to diagnose it, and basically just go beyond the laboratory aspect that we do have, instead of just over relying on the laboratory aspects. Now have the visual examination findings and be more confident to now try and differentiate it from other diseases, especially STIs. So that is what I would say for now.
Great, thank you so much. I'm happy for Robinson or Simon. Like, what next? What next? Simon mentioned, yeah, go for it, Robinson. I see you've taken yourself off mute.
All right. Yeah, thank you very much. So in terms of advocating for FGS, and I like what Kana said about using data and using evidence, implementation or operational science approaches to show the utility of integrating FGS in HIV and SRH. I'll start that by giving a very interesting experience that I had late last year. So I was having a chat I was in a meeting with a team that were implementing CDC PEPFAR-funded HIV interventions, and we challenged the team to start asking about genital schistosomiasis in the routine programming. And we had clinicians who offer voluntary male medical circumcision, those who are offering Fisher for programs, and of course now those who are offering cervical cancer screening. And the clinicians who are offering male circumcision, and now this has a gender lens, some of them are surprised. They said, yeah, we've seen symptoms, what you're describing as symptoms of genital schistosomiasis, but they didn't actually know it was FGS, as Dr. Gamba pointed out. So when we start integrating into routine integration and also showing the funders in the regular reporting that yes, as much as our technical implementation is about HIV and SRH, when we integrate FGS or other genital schistosomiasis into routine programming without an extra budget, we can integrate this. So that can be a basis for further implementation using stories from the field. So that's one of the things that I can mention from that things.
Okay, thanks, Robinson. Trisha, any kind of what are next steps or strategy-wise around integration that you would advise others? Like, who do they need to talk to from an advocacy perspective, both from your experience globally or nationally?
Thank you once again. I think just a few things I would like to add. One of them is being able to ride on the HIV integration agenda. I think this is not just a global agenda, it's at national level. There are committees that are already having discussions on this. So leveraging on that conversation and adding FGS into the discussion so that the packages that are being developed for providers capacity building can actually have FGS into it as part of the package that is rolled out. And just ensuring that we are able to do our mapping of who is funding HIV work, and especially in the areas where there is a high rate of FGS, and starting to have those conversations with such funders and drawing the link between FGS and HIV so that it is clearly understood and we generate the interest at that level. Looking also globally on how do we influence, shaping of the advocacy agenda based on the evidence that we have, ensuring that we engage on those global platforms. So like even the discussions on reducing new HIV infections as they happen at those HLM levels, how do we find our way into those kind of tables and conversations and begin to include FGS in those discussions.
Great, thank you so much, Patricia. And then I will hand it to Simon. What kind of advice, next steps?
Thank you, Felicia. One more thing I think I need to add is that what we have also decided is to work with the NTD department and bring it into the HIV prevention technical working groups. They need to come in as a member because they haven't been involved to the list with HIV, and they're very blank about it. So we felt that their presence during HIV prevention technical working group, during reproductive health directorate technical working groups is going to bring another level of influence because they will also be advocating based on the experience, and these are all government departments and they can easily influence and look at how best integration can come in. So that's one other area that we're working into to make sure that we have introduced them and they must attend each and every technical working group and start talking more about FGS. Thank you.
Great, thank you so much, Simon. I think both Simon Robinson, Patricia and Victoria, I think that one of the things that I think has, and I've seen from your examples is around how to bring it into, FGS integration forward and into global fund opportunities, or including in the National Strategic Plan. It's this role of bringing together and convening, and this exchange and shared platforms. I think that keeps coming back to me around, and then also the from the HIV perspective, bringing the community-led aspect and links into the gender-based violence and into that integrated SRHR, comprehensive SRHR space. And then I know that Simon had mentioned earlier that one of the the priorities was around including FGS as how it shows up in the NSP and other kind of national policy spaces. But I see your hand raised, Kate. I'm just going to ask Leora to actually, Leora had a really practical example of inclusion of, I believe it was hepatitis C in a global grant fund that was not already included into the NSP. Then I'll hand over to Leora. Yep.
Sorry, Fee, the reason that my hand is up is because we're going into the last 10 minutes.
Yeah.
We're 22 minutes past now. So we have a decision to make about how much time we have.
Yep.
Now for the summary slides. So
yeah. So what we'll do is Leora will kind of share her experience, and then we'll move into the summary. Great, thank you.
So just something that happened in South Africa was that the PR in South Africa was running a People Who Inject Drugs program, And initially, hepatitis C was not written into the grant at the beginning of the grant period. And it came up in the course of the grant implementation period that hepatitis C was obviously a need for that population. So the PR, the principal recipient, agreed with the Global Fund to do a pilot program using savings within the grant period. And from that, that we were able to get data on hepatitis C prevalence within the group of people who inject drugs. And from that process, the Global Fund obviously then noted that it was a need and a need within that population, and that it needed to be funded. And so in the next grant, it was actually written into the Global Fund grant. So an example, the example just demonstrates that even if it's not written into the grant right at the beginning of the grant period, there are opportunities during the grant implementation process to make use of reprogramming opportunities, savings opportunities, to get something that you see as a need integrated into the services. So FGS integrated into an adolescent girl and young woman program, for example, as part of the SRH service delivery, I think could be possible, even if it's not written initially into the grant. So that's just a quick example. And because of that now, South Africa has a really good gauge of hepatitis C prevalence, and they're now actively implementing hepatitis C testing and treatment for people who inject drugs. Fee, do you want to do the takeaway points?
I don't. Oh, you mean like show them? Or do you want?
Oh, no, from the panelists, or shall we just move into the summary?
I feel like we've done quite a lot of there's been quite a lot of good advice that has been shared kind of throughout the session.
Mm-hmm.
I did want to maybe give Dr. Gamba, because she wasn't able to join us earlier, maybe ask Dr. Gamba if you could give us like a key takeaway point around engaging doctors and healthcare workers. How do we actively engage like networks of doctors and health workers to engage on FGS? And then after Dr. Gamba, I think we can move into the summary.
Thank you, Felicia. Yes, so there are different cadres of healthcare workers that we can get to. And mostly, if we look at it, there are those ones who are in training, those who have completed training, and the ones who are actually in practice. So it's a matter of trying to look at what is the best way to approach it. And I think starting from while you're in training, to understand that you can actually diagnose FGS via visual inspection. I think that is one way. We have the FGS book that was released by the WHO. I think that is something that we can work on and try to use it also and integrate it into the syllabus. While the other ones who are actually practicing, I think the best way we can use is actually using their societies or even going to the hospitals themselves. So we've had quite an amazing feedback in Kwale County, where we've been working most recently. And based on just building their confidence, you can actually see that we're actually getting some of those cases. Well, we may not have the exact prevalence, but we're actually picking up the cases. Then that brings about the other issue, availability of praziquantel. But at the end of the day, I think it's good to create the demand from our side and also from the patient side. So we're creating demands on both aspects so that we actually diagnose and treat FGS. Yeah.
Thank you so much, Gamba. I think that Dr. Gamba, I think your emphasis on like creating demand on all sides is so important, because I feel like this is what we're hearing as well across the different panels and the resource people together today. So I'm sharing my screen. Yura, are you able to see this? And maybe I'll pop it into slideshow.
Yeah,
Does that work?
Yeah, perfect.
Okay.
So I think a lot of stuff has come up. So hopefully the summary captures most of it. But essentially, as a summary of this session and all the really important information that the panelists have shared, we can see that NFM4 offers opportunities to integrate FGS in the SRHR work and integrating it into the HIV service delivery. And it's also a possible entry point for addressing gender inequality and gender-based violence. And another point is the importance of engagement in the country dialogue process cannot be overemphasized. FGS has to be come up in those dialogues and be highlighted and raised as a country priority for Global Fund to consider having that in the grant. What we can see from the FGS integration experience is the need for engaging early in the advocacy journey with government and donors to ensure that FGS is referenced within key national documents. We know that some countries use the NSP as basically the roadmap for the Global Fund grants and for other grants. And so as Simon really highlights, is that it's so important to get it into the National Strategic Plan and other key documents. Another point was how to integrate FGS within diagnostics and prevention. Focus on prevention through existing services and peer sessions to reduce cost implications and support acceptability within NFM4. So trying to really make sure that we try and integrate with existing programs, use existing staff, use existing spaces, and use those programs as and the audiences of those and the clients of those programs as and use the opportunities that you have with them as key opportunities to address FGS. Next slide. From the Kenya experience, Patricia and Robinson highlighted the need to focus on person-centered care, the integration into peer mentors training and interventions in the Dreams HIV project was a really good example, and how they included FGS in ongoing cervical cancer screening and follow-up, and also just the importance on working on educating and training healthcare workers on FGS, which Dr. Gamba also highlighted. In Kenya, and I think Malawi also spoke a little bit about this, is just the importance in local ownership, working closely with your county or your provincial governments and those management teams, working with the communities, working with the National Ministry of Health on materials, because that helps scaling it up to counties, as you could see from the Kenya example. FGS integration within health, financing, budgets, and health information data were challenges, but opportunities included integrating FGS into the healthcare worker training, pre and in-service training, and using your counties as important allies in influencing donors. Next slide. And then in terms of the Global Fund process, Canna really highlighted the need to ensure that FGS appears within, well, we all highlighted that FGS should appear in some national documents. So there's a lot of local level advocacy that needs to be done, as Kenya highlighted, on your county or provincial level, as well as your national level. But also that only, once you show the link to HIV, will it be, acceptable within a Global Fund application. It's important to build evidence and research and show community evidence to ensure the gender lens. So essentially, the Global Fund will also be really keen to see data and costings and, the importance of high impact interventions. So there's a lot of work to be done in some countries, we understand, to get this information. But I think if we all start working now towards that and start the advocacy with government slowly, it is possible. Beyond NFM4, health worker training to raise awareness on FGS, going beyond lab diagnosis, but also training on visual examination and working with professional societies and hospitals in your countries to get them on board with FGS, to leverage on the existing HIV integration agenda and bring FGS into those discussions with technical partners, funders, and also engaging on global platforms. And you can do that through platforms such as FIG, etc., which Fee is going to explain to you now.
Great, thanks. Sorry guys, I was not on mute. So yeah, please, thank you everyone for coming to the session, and thank you for all of our panelists, and to Allison, Kate, and Chris in the background doing all the chat work and the summaries. And let's keep talking. This is it is this is our first webinar in the series, and we will send the slides, and we will be doing them also in English and French, and the presentation. And you please, any of this, if you'd like to know more, please contact Christine Kalumi. Her email's on that slide that I'm hopefully sharing. And also we will be sending a series of just like resources for you, and do please keep connected, keep in touch. I know there are others on the call today that have extensive experience around FGS and would just love to reach out from the FGS integration group. For those who are working in Nigeria, I've seen Dr. Ibrahim on the call, who is leading the FGS Society. I see Isis Umbalino Walker was on the call, who works for the Bridges to Development, who has been doing health provider training. So please do, if you're happy to pop your name in, and we will also just keep this dialogue going now that we're connected. Anyone, Leo, I think, no, we're over time, but thank you everybody, and watch this space. We will be sending out information to you, and thank you very much, and good luck everyone.
Thanks everyone.